I think I'm audible.
Hello.
Hi. So myself, I am Ashley and Policy. So I will be coordinating this FCPC. I hope I am audible.
Yes, you're audible.
So yeah, once again, my name is Ashley and Policy. So I'm the virtual education coordinator from Pallium India. Before starting the session will start by 3 p.m. So before starting the session, just a small intro about Pallium India. So Pallium India is a national registered charitable trust which was formed in 2003, and it is an NGO based out of Trivandrum, Kerala, which is the objective of alleviating serious health related sufferings of 7 to 100 million, 10 million people in India. And this is our Pallium India model. So it's facilitate, educate, and demonstrate. And in the demonstration, we have like clinical inpatient and outpatient services, as well as link centers, and also home care. Sorry for that. And this is our tips training program, which is like we have like a residential online and as well as we have also on-site training. And we do train for the doctors, nurses, health aligned care professionals, volunteers, which is of a general public. And also we have student volunteers, palliative care beneficiaries, and the specialists. And these are the programs which we are currently running in the online session, which we have like foundation course in palliative medicine, nursing, and this particular course, which is foundation course in palliative care, pain-free hospital initiatives, and many more foundation courses. And telling about our foundation course in palliative medicine, just giving a brief intro that we have like 16 sessions will be there, which will start from today and will end by 30th May. And we have like 2 sessions per week, which is on Mondays and Thursdays. The time is from 3 to 4:30. And the criteria or the rule for certification is that we require 80% of attendance, that is live sessions with video on. And we request every participant to switch on the videos while we are taking the sessions. And we also require 70% score in all assignments. We do have 2 assignments. Out of assignments, we have like pre-test. I hope everyone has completed their pre-test as well. If anyone has yet to complete, please fill the same. And also we have post test and end evaluation as well. And this particular session we are logging through IACO platform. So all the learning materials, including the faculty PPT presentations, the video links of every sessions will be uploaded in the YouTube, so that you can view if you require in the future, as well as all the reading materials. Everything will be uploaded in the IACO platform, and also the certificates will be issued on the base of this program only, and all the communications will be made through this email address, that is tipseco@palliumindia.org, or the WhatsApp group. And about our session structure, we have like a 1.5 hour Mondays and Thursdays. So the first 5 minutes will be a general introduction of the faculty and the participant, and the next 60 minutes will be the faculty presentation. And after that, we do have a case presentation. So today, after the presentation by faculty, I will be sharing a case presentation model, just a model for your general information. So that's all about our case presentation, and that's all about our this particular course brief intro. So is there anything to ask, or else we can ask it at the end?
Just that the audio can be a little more louder. It seems a little distant.
Is now it's fine? Is it now okay?
It feels the same.
Okay. What about now? Is it clear?
Yeah, a little better.
So I
Hi,
think
Ashley. Will you be sharing the recordings of the sessions after each one?
yes, the recordings will be shared in the link of each sessions will be shared in that IACO platform. So we will
Okay,
share
thank
the link there, so you can take it from there. So yeah, we can start the session by sharp 3. So the faculty has also joined. We can wait for another 2 more minutes to join others also. Can just wait. So I think we can start up the today's session. So once again, those who have joined lately, my name is Ashley M. Palsy. So I will be the point of contact for this particular foundation course in palliative care. So today we have the session on introduction to palliative care. So the person who will be going to take, hello? Is I am audible?
You are
Yeah.
audible.
Yes.
Okay, so the faculty for today's session is Ms. Smriti Rana. So she is the head strategic program and partnership division at Pallium India. She as a trained psychologist, Smriti ma'am began her working in palliative care in the year 2001 after the loss of several family members in quick succession. Her focus Her work focuses on ensuring safe access to opioid LGs for the pain relief in India by engaging with central government and other key stakeholders. She has become a spokesperson for civil society perspective from LMIC on various platforms, including events hosted by Vienna NGO Committee and also UNODC, and was a part of expert group that developed the WHO technical report on globally applicable indicators to assess the monitor provision of the palliative care services. She is the lead capacity bridging program for Pallium India and works for the improvement, death literacy, appropriate end of life care, and for the inclusion of the persons with lived experience at the decision making forum. She advocates for the decolonizing healthcare and is passionate about the role of storytelling in humanizing health delivery. She is the head of WHO Collaborating Center for Training on the Policy of Access to Pain Relief, the Indian Advocacy Focal Point for International Association of Hospice and Palliative Care, and is the vice chair at the International Drug Policy Consortium. So I welcome you, ma'am, for taking the sessions, and I welcome each one of you and have a great learning today. Ma'am?
Thank you. Thanks, Ashley. And am I clear enough? Audible enough?
Yes, ma'am, yeah.
All right, fantastic. So welcome everyone to the foundation course in palliative care. And thank you to those who put on your cameras. I think it's very important for us to be able to see each other at least while the presentation is off, so that we humanize one another for one another also. a little bit before we actually get into the session, I graduated as a psychology major couple of decades ago. And at the time, even though I had an interest in palliative care, there was really nothing for me to study. And so over a period of time, we've developed this program primarily to introduce you to the salient ideas and philosophies behind palliative care that we practice in India and other low-income countries today. We're not looking at actually doing intensive skill building in terms of counseling skills and things. We are hoping to create a new program by the second half of this year for that. But really today's series, the series that we're starting today, is to introduce you to what palliative care looks like in the country and what the various issues associated with that and how you can possibly connect with us, connect with organizations across the country and become a part of the movement. A couple of other things also that I'd let you all know right from the start is that we'd like these sessions to be interactive. The chat box is open right through the session. So you can put in your comments, your questions, reflections. I invite you to share experiences. And from time to time, I will stop and respond to some of the questions that might be in the chat box. In our experience, these sessions can trigger some powerful emotions because we're talking about illness, we're talking about care for people with advanced and terminal illnesses. I don't think there is anyone here today who has not at some point been touched by caregiving, illness, or bereavement and grief. So we do touch upon those topics. And if at times it does become a bit heavy, you can send me a direct message in the chat box, or you can write to one of the facilitators. If we need a debrief with you, we'll be happy to do that. And one request I do have is that also many a times you feel compelled to share an experience that you might have had with the healthcare system, where you've not experienced palliative care, or you wish you had experienced palliative care, or you've had a powerful experience with palliative care. I request that those reflections be saved for towards the end of the session, because as facilitators, it's not easy for us to just skim over something someone has shared without attending to it. And that sometimes it interferes with the time that we might have set for the session itself. So I welcome you to share. I hope by the end of this series, we get to know each other and maybe even work together in some capacity. But do save your personal sharing for a little bit later in the session so that we can attend to it and give it the time that it needs. Okay. All right. So I'm just going to do a quick check-in. We have 39 people here, including the Pallium tech team and I. Just one word in the chat box about what's your emotional state right now. And I mean emotional state. I don't mean sleepy and hungry and things like that. Just how you are. What is the emotional state? Just one word, just for us to get a sense of what's happening in the room. I know it is ridiculously hot in a lot of places that we're at, so maybe that's sapping your energy a little bit, but I'd love to just get a sense of what everybody here is feeling. One word, two words, so that we know, at least I know how to tailor the session as we go in. I love to see that there are happy people here. It's not a word we see a lot in palliative care units. All right. Anxious. Okay, I hope we can address some of those anxieties by the end. All right. Great. Keep them coming. I will also ask how many of you here, by a show of hands, have had experience with palliative care before. You can use the emoji, the reactions in the panel below. Okay, how many of you have had prior experience with palliative care? All right. Okay, so I'm seeing that. Okay, I'm seeing that it's in the minority. Okay, so I'm going to assume I'm going to assume that a lot of people here have not had experience with palliative care. But for those of you who have earlier, you might find some of the concepts quite familiar, in which case do help me clarify concepts and ideas. I'd love to hear what the practice looks like in your settings, and let's just all learn from one another. Okay, so let's get into it. Let me just find my screen for you to me to share. Like I said, we're just gonna go over the major aspects of palliative care in the way that we practice it in our setting. And some of you who were here earlier, and Ashley was telling you about the work that Pallium India does, we work across the spectrum from clinical services to education and training to advocacy for change at the policy level, at the legislation level, and really to work from the most remote and rural parts of India to tertiary care hospitals in metropolitan cities. And what we're really here hoping to do is to integrate palliative care into the larger healthcare system in India. A very uphill task, but I'm very encouraged every time I see people who've never had anything to do with palliative care join these courses, and in that way become connected to us. Okay, let me just share my screen. Ashley, are you able to see it?
Yes, ma'am.
Okay, great. Okay. So before we talk about palliative care, let's talk about healthcare. And healthcare, as defined by WHO, is not just the absence of infirmity and disease. So sorry, for some reason it's hanging. Hang on. Just give me a second. Always there has to be a technical glitch. What is a class without some technical problems? Okay. My apologies. Okay. So, yeah. Okay. Is it visible?
Yes, ma'am, it is.
All right, great. So according to WHO, health is not only the absence of disease and infirmity, it is the presence of physical, social, and mental well-being. So not just the absence of disease and infirmity, but the presence of physical, social, and mental well-being. How many of you today believe that our healthcare practice actually looks at the second part of this statement? How many of you believe that our healthcare system is as invested in physical, social, and mental well-being as much as it is interested in removing or mitigating disease and infirmity? Yeah, it's not the same. Sharla and, okay, so I'm assuming that Sharla and Nidhi agree. Okay. They're not given importance. Socially, not okay. Yeah, I'm reading the chat, the chat inputs. And yeah, I mean, the focus a lot of the time is to just get rid of disease, fight the disease, fight the illness. We're not really looking at what well-being looks like to the family. And I'll demonstrate, I mean, I'll illustrate that point in the next few slides. So I'm showing you a slide about the National Crime Records Bureau in India. Why am I showing you a slide about the National Crime Records Bureau in India for a palliative care program? Now, in 2014, about 1/5 of the people who chose to end their lives were people who were suffering from different chronic and advanced ailments, cancer, HIV, people who had paralysis, and they chose to end their lives by suicide. And in 2021, deaths by suicide reached an all-time high, and illness, again, was the second most important cause, or the most common cause, or major cause. Now, if you just look at the statistic, what does it tell you? the most major cause is, domestic issues. The second highest cause for people choosing to end their lives in our country is that they have an illness. So what could be the possible reasons for why these two statistics are linked? And please feel free to unmute and speak. I'm happy to hear from you, or you can use the chat box. Why is it that the second highest cause for suicide in our country is amongst people who are living with a serious illness? Okay, Neeta says negligence.
Mental health issues.
Mental health issues. Do you want to elaborate on that a little bit, Uma?
Yeah, because chronic illnesses, all these can give rise to mental illness. Just now you said that in healthcare, it's a social and spiritual and mental well-being, but that's not taken care of. So what we are pushing is only chemotherapy, radiotherapy, and all these drugs. So probably their mental health is not taken care of, and that's why they go into depression and take extreme steps. That's what I
Thank you.
feel.
Thank you, Uma. You're absolutely right. Mental health issues is one aspect, definitely. And I see that a lot of people are now saying, warming up in the chat box. So feelings of helplessness, suffering, financial suffering, no one to listen to them, loneliness, depression, lack of awareness, feelings of helplessness, being a burden, etc. So, I can't actually find a single study that links these two statistics, but any one of us, if we apply our mind, can really understand why this might be so, right? It doesn't really need that much stretch of the imagination. It's quite obvious. And so all of you are absolutely right with all the different reasons that you've put in the chat box. And in 20, so there is this, The Economist, the Lien Foundation is this organization in Southeast Asia, and they had commissioned the Economist Intelligence Unit to carry out what is called the Quality of Death Index. And the Quality of Death Index, it was done twice, in 2015 and again in 2021. Now, what this measured is how do people die in different countries? And the way in which they did it was to look at healthcare resources, of training, of awareness, of pain, of suffering, all of those things. Those reports are available online, and we'll be happy to share them with you. And in 2015, out of 80 countries, India was 67. We haven't moved very far. 2021, we were 59. If you look at the topmost countries, they're all global north countries. Global north countries are Western developed countries. Majority of the countries who have poor quality of death index, or who have a poor quality of death, are usually from low and middle income countries. Now, of course, there are a lot of variables to it. I encourage you to read the report. I'll also say that while we're talking about death and dying, palliative care is not only about death and dying, but these are just some frames that I want to put forward in front of you. Now, what is the impact of healthcare in India? As per a report in 2017, catastrophic out-of-pocket healthcare expenditure pushes 55 million Indians below the poverty line every year. 55 million Indians are impoverished as a result of out-of-pocket expenditure for healthcare. And of these 55 million, 38 million are pushed below the poverty line because of the cost of medicines. What does this tell us about a system that is supposed to be designed to relieve suffering? It actually adds more suffering to the family. It adds more suffering to the patient. And this could possibly be one of the reasons why people choose to end their lives, because of the financial toxicity of being an unwell person in this country. So these are just some hard facts out there. It's something for us all to understand. And then I will tie it up to palliative care. Now, there was something called the Astana Declaration. All of you know Sustainable Development Goals. You know the SDGs for various things. Health is one of them. And one of the things under Sustainable Development Goals was also universal health coverage. And this was talked about extensively in Astana, which is in Kazakhstan. And they said these important things. They said quality healthcare should reach people where they are, when they need it, at an affordable cost. So where they are, when they need it, at an affordable cost. So it has to be accessible to people, and it has to be affordable and available to people. And health for all has to be health with all. And you have to include communities and people in designing and controlling healthcare systems, because healthcare looks different in different settings. You cannot have a template that works for everybody. So you have to involve communities in designing and controlling their own healthcare systems. Now, all of this sounds fantastic on paper, doesn't it? But what is the truth? The truth is very different. We do not have accessible healthcare or affordable healthcare wherever we want it. We don't have it. People are hardly ever consulted in the policies and in when framing policies or coming up with SOPs or things like that. But this is the ideal. Okay, so let's just put this aside for a minute. Now, I want to tell you this story, which is it's a little bit of a well, it's an important story, although it's a sad one. This was in 2016. Some of you might be familiar with the story. It was all over the newspapers. This story was carried that this man who was 30 years old, he basically moved a district, a lower court, for permission to euthanize his son, to kill his son, because he said that his son was in so much pain, in so much suffering, that the family could not bear to see him in that condition anymore. Of course, he was denied it. Euthanasia is not legal in India. And we will be talking about, some of that further down the line. But of course, he was denied it. And so when we read this story, there were a bunch of us in the southern Indian states who mobilized, our teams to find where is this man, where is this boy, where is this family, and how can we help them? And our trail led us to Hyderabad, to Madras, to Bangalore, to a couple of other places. And in fact, in Hyderabad, the hospital that he had taken his son was actually a stone's throw away from one of the best pediatric palliative care units in the country, but this boy had never been referred to them. We finally found this family in an ICU. The boy was in an ICU in a small hospital in Bangalore, and a social worker went across from Hyderabad with prescription medicines for pain relief from a pediatric palliative care physician. She went across to Bangalore. She was denied entry, and this boy died in excruciating pain while the social worker was standing right outside with the pain medication. And that social worker had a very hard time getting over that. But this is the sad reality for a lot of families. And there are also families who have, who have actually ended up killing somebody in their family and then choosing suicide for themselves because it was just unbearable. The pain was unbearable. They had no more money left, and there was a whole lot of other issues that happened. So this is not a very far-flung story, because you'd be amazed at how commonly this occurrence happens. As we heard about this because he had actually tried to go through the legal system. And so setting the stage with all those like very grim and sad statistics and stories, let me now come to what we're here to talk about, which is palliative care. Firstly, what is palliative care, right? There are lots of ideas people have about palliative care, and some of them, part of our job really is to dismantle the myths, because palliative care is surrounded by all these misconceptions. The first is that palliative care is only for people dying of cancer. Dying of cancer. Okay, a lot of people think palliative care is only for people dying of cancer. The truth is that palliative care can benefit not just cancer patients, but any patient living with a serious condition, any life-limiting condition even, doesn't have to be a life-threatening condition, life-limiting condition like maybe a stroke or, a spinal cord trauma, and it really can benefit them and their families from the time of diagnosis. So it's not only for cancer patients in the terminal stages, it's for anybody living with any of these conditions from the time of diagnosis. A lot of people, unfortunately, believe that by choosing palliative care, they're choosing to give up. And I've worked with so many families in the last 20 years where they said, but we're not ready for palliative care. We're not ready to stop fighting. What they don't realize is that you're not stopping to fight. You're not stopping the fight. You are continuing to do what you need to do, but you're also tapping into a system that is there to provide symptom control, that will reduce your suffering, and that will look into aspects that modern day technocratic healthcare cannot look into. And the loss of, a lot of people think that if they stop doing interventions, if they stop chemotherapy, if they stop all these, expensive treatments, that means they're giving up. But at some point, we have to reframe the care, because at some point, some of these interventions become futile. And removing those is part of our job, not the ones that are still working, but the ones that are futile. And so people can live a life of quality. They're not, stuck in an ICU with tubes and wires and not able to be around their families. A lot of people believe that palliative care hastens death, and that is absolutely not true. No matter how much time a person has, our job, primary focus, is to provide comfort and the best quality of life. And that could be for 10 years. It can be for 2 weeks. It could be for 10 years. It could be for months. We are not about hastening death at all. And pain is a part of serious illness, and it has to be accepted. And this is a myth that is so pervasive, that suffering is part of my destiny. It is part of my experience. It is what God wants me to experience. And it is worsened by the fact that till 2019, palliative care, elements of palliative care, pain relief, and end-of-life care were not part of the medical undergraduate curriculum. Can you believe it? So till 2019, you had some aspects of pain management, but pain management and its elements were a non-examinable subject. So it was not something that people paid attention to. And if I'm going to study 5 years to become a doctor, and if someone tells me, yeah, we're not going to examine you on this particular topic, what am I going to think? Of course, it's not important. It's not an important intervention. So it's only in 2019 that this became a part of an examinable part of the medical curriculum in India. So we have generations of doctors who are not tuned to treat pain adequately. Okay, and that is a serious problem. And the idea that pain is a part and parcel of illness is something that we really need to do away with. We have the means, we have the resources, so that a person does not have to suffer pain in addition to their disease. And it can be and should be alleviated. Of course, there are some folks with spiritual and religious beliefs around this, so we're not talking about that. We're talking about those for whom pain relief is not even available simply because the system doesn't allow it. A lot of people assume that morphine, once it's administered, would hasten death, and that is absolutely not true. Appropriate doses of morphine can keep people comfortable and absolutely not hasten death. It doesn't work like that. And a big deterrent is that taking pain medication like opioids for pain relief will lead to addiction. And it has been our experience over 20 years that appropriate doses of morphine, the doctors have learned how to titrate and give appropriately, especially immediate release oral morphine. It will not cause any kind of addiction. And this is a huge, huge, huge deterrent to people actually accepting pain relief. And this is a very poorly understood aspect. So this is something that we're hoping to debunk, this myth, as we go along. Okay. Any other myths? Any other ideas that I might have missed? Has anything here come as a surprise to anyone in this group? Anything that has come as a surprise? Or
I think one of the myths is that palliative care can be very expensive.
Really? Oh, okay.
Yeah. Especially if the treatments already taken are expensive, then adding palliative care to that seems prohibitive.
Okay. I'm very interested to hear that, actually. How do you say your name? Is it Shalaka?
Shalaka, yeah.
Shalaka. So perhaps that is something that is pervasive in, say, metro cities, tertiary hospital settings. Although even there, I mean, most of them don't even have palliative care services. But by and large, across the country, palliative care services are free of cost. For most part. In some tertiary hospitals, they might be cross-subsidized, but they are not prohibitive. In fact, good palliative care will actually bring down the cost of treatment, because you're not rushing to the ICU, you're not rushing to the hospital, you're able to take care of people at home, you're given that sort of training even as caregivers. So we actually reduce the number of hospital visits and so on. So it's really interesting for me to hear this, and maybe I need to do a little bit more research to see where
Yeah,
these
because Smriti, what you're saying is, you're assuming that everybody already understands everything about palliative care. Most people don't. So
Yeah.
even if it's just, they know just 5 sentences about palliative care, the first thought in their head is, oh, I can't add on to the current expenses without
Got it.
even checking out, what the pricing is out there, because
Yeah.
nobody has ever told them where to go and, what to ask for.
I understand what you're saying. Yeah, thank you. Thanks for that. Thank you for that, Shalaka. Another myth. Sorry, Niharika, would you like to say something?
Yeah, I completely agree with Chalaka. Actually, the same happens with me. Like I work with palliative care setting. So most of the patients, when they come and when my doctor counsels them, so they are always worried about the cost of the treatment. I also come across this problem.
So I suppose, yeah, and this links to what their journey has already been so far, right? I mean, the cost has just added on, and somehow now suddenly it's a new thing that is being suggested. And like you said, there's probably not a lot of information around it. We've also experienced sorry, please go ahead.
Yeah. Also, I think in a certain like insurance also, like we have to mention supportive care. Like so far, like only one patient was not covered for the treatment, or the rest of the patients were covered. Also, once they opt for palliative care at home, so that adds on to their cost, because there are a lot of equipments and in nursing charges, support charges. So that is not covered in the insurance. So that adds on to the cost of the treatment.
Yeah, and that's a very valid point you've made, because palliative care is now as under I think the Ayushman Bharat scheme and the insurances and stuff. It's only for cancer patients, and it's not covered for for patients who have non-cancer conditions. So you're right about that. Thank you for that. And we've also had the experience in some settings where people don't want palliative care in settings like ours, where it's free of cost because they think it's a charitable service. And then it looks like they're not giving their family the best care because we're not charging,
Right.
so that dichotomy, that paradox is there in both,
Yes.
in both ways, I suppose. Yeah.
Right.
So what it basically is saying is that there is so much misinformation or lack of information around what palliative care is, how much it costs, how it can benefit. Yeah. So, yes. Yes, please, Anita.
Yeah, I think main thing would be about awareness about palliative care. I mean, there are a lot of people who actually are not, who don't know about palliative care.
Yes.
They always think palliative care is, end of life, like how you mentioned earlier. But most of the people which I see are not aware of what are the services and how much dedication is there from our team of doctors, nurses, and social worker that help them to up their life when they are not well.
I absolutely agree, because I mean, a lot of it just boils down to lack of awareness. Either way, whichever way you get it. Yeah.
I think, Smriti, just one last point I wanted to make.
No, please go ahead.
Palliative care in India has a marketing and branding issue, and obviously starts with an awareness issue. So, the problem starts there, and once these issues are also resolved, and people like yourself, the leaders in the palliative care movement here in India, start looking at these issues seriously, I think things will change on the ground as well.
I couldn't agree with you more. This branding issue, I mean, it's very hard to market palliative care, right? Because even from the point of view of funding, I've had someone in CSR tell me, but it's not a winning cause. And my question was, what do you mean winning cause? Like, it's not a winning cause. It's not curing anything, So we'd rather support a cause like research towards the cure for, a kind of cancer or whatever. And on the other hand, I'll also say a huge issue we have is that the way palliative care is practiced in the West and in lower income countries is very different. So in the West, it is usually hospice care, end of life care, and so on. Whereas in us, the way I look at it is it's a social intervention, not just a healthcare or a medical intervention. And it's very difficult then to get consensus on what palliative care really means, because in some cases, I mean, there are some excellent organizations around the country, but they only work with cancer. Or there are people who are around the country who work with, say, non-cancer conditions, but they're very localized to a particular city. And then there are people working in different spaces where they say, okay, I mean, I'm going to be talking about it a little bit later. So the consensus around what palliative care in India is, what it should look like, is also, we haven't gotten there yet, and it's not for lack of trying. Now, I saw someone say it is supportive care. A lot of people will say, stop calling it palliative care, call it supportive care so that it has better uptake. Now, after a while, then supportive care will become stigmatized, right? So that rhetoric, that language, there are a lot of issues that plague us. And you're right about the fact that we need to come to some sort of understanding of what it is and then really get it out there. One of the most difficult groups to convince are healthcare workers themselves and the healthcare services and healthcare professionals. Also, I will say this, palliative care is not a lucrative, it's not a lucrative field. And in today's healthcare system, there is the profit margin, there is those targets. So there is already an inbuilt sort of resistance to what we're bringing to the table. So yes, lots of different issues, but thank you for highlighting these. I'm glad we're having these conversations. I'm glad you're telling me what the myths are like to you, because sometimes we are so used to looking at something in a particular way that we don't realize that the narrative has actually changed, and that is also problematic. Okay. Great. Please keep your comments coming in, and I'll try and address them as we go along. All right. And addiction, of course, like I said, addiction has been a major deterrent, and we'll talk about that in another session, specifically addressing addiction. Okay. Now, as most of you already seem to be quite aware, palliative care is it's active holistic care. This is it's a mouthful of a definition, but this diagram really sort of sums it up, that right from the time that it is detected and diagnosed, you can actually bring palliative care in. And it comes into sharper focus, takes on more responsibilities as the disease advances and as we come towards end of life care. But it is something that we can work with attending teams right from the start. And like somebody said in the chat box earlier, that it's not just for the patient, it is for the entire family. And that is something that is poorly understood as well. And so typically you would have life-limiting illness, you have terminal illness, there is a phase of pre-active dying, and then there's active dying. And so as we move into these concentric circles, palliative care becomes more and more, it comes into sharper focus. Okay. But palliative care has a role to play in all the phases and layers of the disease. So while we're still living with life-limiting and life-threatening conditions, we can offer psychosocial support. We can maximize community support. There is palliative chemo and radiation as well. There's palliative surgery, symptom control, all of those things. As end-of-life care approaches, the focus shifts a little bit more to supportive care, to symptom management, to spiritual care, to, again, psychosocial care for the family, getting them ready and preparing them for the trajectory ahead. And also terminal care is the last few days of life. And again, what we focus on there becomes quite, in the sense of we're very particular about what we're focusing on, what the conversations we're having, the decisions that we're helping the families navigate through, so on and so forth. This is a graphic that we had created some time back, because perception of people is that it's end of life care, that's it. But palliative care really is so much more than just end of life care. And especially in low income countries where we don't have where treatment does not reach people adequately or in time, there are no specialized verticals taking care of certain disease groups. A lot more people come under the under the ambit of palliative care. And for that, we need community support. And of course, pain relief and symptom control is a part of it, but there is so much more than that. And family and caregiver support is a big part of it. Restoration of dignity. Dignity is a big aspect that doesn't get talked about as much, but now more and more that language around dignity is coming in. And empathetic communication, just overarching everything. Learning how to communicate with the family, with the patient, with other healthcare workers, with other disciplines, within your own team, interdisciplinary communication, all of that becomes so important. And it has to be done empathetically and competently, not just empathetically. So we have a concept called total pain. It's pretty much, in one way, one of the cornerstones by which we understand what palliative care takes into consideration. Let's just do a quick thought experiment here. I want you to imagine that you have a headache. It's a regular kind of headache, not a migraine or anything. And it's on a Sunday afternoon. You've just finished all your chores, and you can now put your feet up. You can relax. You have somebody who will make you a cup of tea or some soup. There's somebody who will come and offer to, rub your forehead a bit. You can take a nap because it's Sunday, whatever. On a scale of 1 to 10, where 10 is the highest, most unbearable, where would you rate that headache? Given that you have all these things happening around you, you have someone to take care of you, you can lie down, you can take a nap, you can, somebody's there to maybe finish your other chores for you. Okay, so Uma scores it a 3, 2 to 3, 4. Okay, 2. Okay, I'm seeing all of it on the lower part of the scale. Okay, same headache. The physical part hasn't changed, but now it's a Monday morning. You have missed 2 deadlines. Your child has vomited all over you in the morning. On the way to work, you have a flat tire. You get a call from your boss saying, "Where are you? Where is that assignment?" And you were supposed to be a half an hour ago. Then you get a call from your teachers at your child's school saying, "This child is quite sick. You have to take him back home." Same headache. What do you score it now? Why did this change? What changed? Stress, support, situation. What else? Yeah, can't concentrate, psychosocial aspects. Okay. So total pain is this. We believe that total pain is not, it's the subjective experience of pain. And when a person reports their subjective pain, it is important to remember that this is compounded by the life circumstances of the person. The same pain can feel like a 2 and it can feel like an 8, depending on what is happening around you. And this was a thought experiment that we just did. You don't even actually have I really hope you don't have a headache after, this whole conversation that we're having, but this is a thought experiment. So if we were to apply this to a cancer patient who has now had to mortgage her house to pay for her bills, who cannot now afford to send her children to the same school that she was sending her to earlier because the financial cost of this treatment is so much. There is nobody at home to look after them. The other caregiver is an elderly parent. All of these things, can you imagine what that pain feels like? So why I'm talking to you about this is that in palliative care circles, when somebody tells me I have a 10 on 10 pain, it is my duty to explore why that pain is a 10 on 10. And very often, the reason is not a physical reason. It is something else that is worrying them. And my job then as a palliative care clinician is to try and mitigate suffering on all those levels. So it could be a social issue, it could be a psychological issue, it could be a financial issue, it could be a practical issue, it could be an emotional issue. I need to find where that person is hurting really. Where is this pain really coming from? And that is also palliative care. It's not just the doctor and the nurse who are looking at it. The social workers the job becomes very important. The counselor's job becomes very important. So that is total pain. And we have to believe people when they tell us that pain is 9 on 10. And what happens sometimes is the doctor will say, oh, he's saying 9 on 10, but just give them pain medication for 4 on 10, because I don't see any organic reason for this person being in that much pain. So that is not something that we encourage. Look at the story, look at the person. What is this person's story, and what are they trying to tell you? And that will tell you what their pain score is, what is the origin of their pain, and how we can actually reduce their suffering. Okay, so like I said, total pain has many dimensions. It could very well be physical. The person is constipated, they're not able to move around, they've lost their mobility. It could be that as well. But there are psychological, spiritual, and socioeconomic factors. And when I talk about spiritual, I want to emphasize this. I don't just mean religious faith, although that is part of it. But what I mean in terms of spirituality is what gives that person meaning, what gives them hope, what gives them connection, what gives them a sense of purpose. And all of those things. For some people, it could be gardening. For some people, it could be their job as a teacher. For some people, it could be music, it could be nature, it could be anything. What gives them a sense of connectedness? What makes them feel supported? So that kind of spiritual suffering is also something that we need to look into. And how do we get people to reconnect with the world? How do we get them to still have a sense of purpose, even though their energies might be diminishing? Those are also things for us to look into. So we've talked about what is palliative care. So we're going to talk about why palliative care. Okay. Now, the usual model, we have the person, and then we have the hospital or the healthcare system. And we have to travel some distance to get into the healthcare system, not just geographically or physically, but also, mentally and cognitively. There's so much we need to navigate before we enter the healthcare system. And we have a dear friend called Dr. Roop Gursahani. You're going to have a session with him. He's one of the leading proponents of appropriate end-of-life care in India. And he was also the doctor who was consulted in the Aruna Shanbag case, if you're familiar with that case. And he says something very interesting. He says, modern day healthcare systems are like fortresses where the rich can't get out and the poor can't get in. And that's quite true in many ways, because, well, as people with money, you pay everything you can, you get into it, one intervention after another. By the end of it, you're stuck alone in the ICU, getting the most expensive care. And then there are poor who just can't get into it at all because they can't afford it. And I'm specifically talking about the Kerala palliative care model, and you will hear about the Kerala palliative care model a lot. As part of the Kerala palliative care model, I will say that we need to shatter this glass, because what works in Kerala may not necessarily work in another system, in another state. And a certain number of variables came together in the Kerala palliative care model with community volunteers, etc. But it's not that you have to replicate the model in other states. Other states and districts have to find their own strengths and then use that to create their own model. And Telangana is actually doing a fantastic job of it under the leadership of Gayatri Pallat. But anyway, what we really look at is bridging that gap between the person and the system by leveraging community. And this has been our success because with our already stretched healthcare system and the personnel, we can't be everywhere. Although Asthana says, meet people where they are, when they need it, that's not possible. We are a country of 1.4 billion people, and we cannot have our healthcare workers be everywhere. So at that point, community becomes important. And I'll give you a little example. This young man here, he was 19 years old when he was in a road accident, and he experienced extensive injuries to his spine, to his head. And so he was in the hospital for a long time, and then he was discharged. And what he was told, what his mother was told, she was a single parent, was that he'll be fine. You just have to make sure that he comes to the hospital for physiotherapy once a week. Physiotherapy once a week, he should get better. He's 19, he's young, he's resilient. So what happens now is that the mother is a single parent. She works in a plantation. The house is on a hill. The house has steps. To get to the main road, you have to come down that hill, over another hill, and walk 1 kilometer to the main road where there is no bus stop. So for this boy to get to the hospital, 4 men, because he's a big built guy, 4 men in the village have to take the day off, carry him on a khatia, on a stretcher, down the hill, up the hill, down the hill again, a kilometer's walk, wait there. The mother has to hire an auto rickshaw to take her 30 kilometers one way to the hospital, where he has to wait and then bring them back. And that is 2 weeks' wages. So the intervention prescribed is very simple. Physiotherapy once a week. Did this boy get that physiotherapy? No. 3 years. And he started to deteriorate. And so our model works on the fact that we train people, volunteers in the community, and because they know their communities best. There's a register. We have a link center, which is basically a primary, it's any public building. So it could be a primary school, it could be a library, it could be, the local meeting hall for the village, whatever. And a register is maintained. Now, if somebody says, hey, that's my neighbor, I think they might benefit from palliative care, they'll write the name in the register. So when our home care teams go, they know that, okay, there's one more person for us to go see, because this person who's been trained by us has recognized that this family might benefit from palliative care. So this is exactly what happened in this boy's case. Someone wrote his name in the register. And as a result of that, our team started visiting them every week. He started getting physiotherapy. And because he couldn't go to the physiotherapy unit, we set up these parallel bars in his house. We trained the mother on how to, help him with some exercises. I'm very pleased to tell you that this boy is now mobile and is and in between he was very depressed. Somebody talked about mental health issues. He's come out of his depression. He's re-engaged. He wants to study. He wants to become a botanist, and he's re-engaged with life. Had we not found him, how would his story have ended? I mean, it's open to imagination. There's no one way it could have ended. Could have ended in several ways. He could be on the statistic for the National Crime Records Bureau, right? So what happens to these people? They're not terminally sick, but their situation can make them terminally sick. You know what I mean? So this is where getting the community involved is so vital. And they don't have to have medical training. They just have to have the eyes and ears open to know who will benefit from it. Okay. Now, this is what one of our link centers looks like. It's a primary school. So once a week, it gets converted to a palliative care link center. Patients and families who want the medicine, who can come to the center, come there. They get examined. This board that you see at the back, that's where the women get examined. But the ones who really can't come to the center are the ones who are most vulnerable. So that's where we need to go to their homes. And oftentimes, the path is undulating. It is not motorable. No car can go there. So this is a volunteer from the village. He knows every single person's house, and he takes our interdisciplinary team to visit these families in their own homes. And one of the things we realized is that there's no point in giving out free medication and medical intervention when families have been impoverished and financially destroyed by healthcare that they can't even afford food. There are lots of people who cannot afford basic rations. So what's the point of giving them free medicine? So now at least 100 families in our care get free food rations from us every month. Is this palliative care? The Western world may not think so, but we do. I mean, to mitigate serious health-related suffering is palliative care. If the family is starving because one person in the family got sick and the family lost all their money, that is part of our problem to fix also. So what we're now trying to do is tie up with other social, with civil society organizations, etc., so that they also work with us to provide these food kits, provide various other support systems. Very often, this is what a home care visit looks like. And those of you who know Kerala, this is a good day in Kerala. It's not raining. So, I mean, these are some of the houses we have to traverse. So imagine asking a seriously ill person to come down these steps to go to the hospital to get care. Earlier today, I talked a little bit about dignity. To a lot of people, their dignity, I mean, dignity is an interesting thing, and I'd encourage you to read the works of Harvey Chochinov. He's written something called Dignity Therapy. It's more Western frame, but it's a great concept. And Harvey and we've done some work together as well. But he says dignity is a very ambiguous, amorphous word. And I'll ask you right now, like, dignity is like love. All of us know it's important, but when I ask you what dignity means to you, it'll mean different things to different people. Right? For some people, dignity is being able to look after themselves. For some people, dignity is about having clothes on their back and giving their children a good education. For some people, it's about going to the toilet by themselves without having someone come and wash them and clean them. I will just put that in. Avi Chochinov, and he's written a lot. Just Google him. He's come up with a lot of really interesting stuff. There's something called the Platinum Rule that he's come up with also recently. All right. So dignity means different things now, but to a lot of people, it's their personhood. Who am I? And where do I get my dignity from? And if I were to ask you your identities today, how are you going to introduce yourself to me? Who are you? If I say, who are you? How are you going to introduce yourselves to me? Chat box is open. I have all your demographic data, but I want to know who you are according to who you think you are. I know there are psychologists, hospital administrators, some social workers, some doctors here, but who are you? Demographic data comes to mind immediately. Yeah. It's okay, but tell me, who are you? A role that you play, a quirk that you have. Okay, let's warm up that chat box. Human being who looks towards helping people in suffering. Okay, wife, daughter, likes to read, independent person, joyful woman. Ashley, please save this chat and send it to me because I think I'm going to have to read it a couple of times before our next also. All right, fantastic. See, now you get sick, you get diagnosed with a serious illness. And what does that illness do? It takes away your ability to do a lot of these things. Or it may not take away, but it will impede or limit your ability to, if you're seriously sick, how are you going to help someone else, Anita? Difference in the lives of others and myself. Daughter, medical social worker. If you get sick and you can't be a medical social worker, then what? Now, what our healthcare system does also is that it reduces people to patients, case numbers, patients with the disease. And I love the responses that are coming in the chat box. Okay. But all of these things, your dignity also is tied to all of these roles that you guys have shared with me today, right? So there are people who are used to being to play a certain role in the family. You could be the nurturer, you could be the provider, you could be the confidant, you could be whatever. And the disease sometimes takes that away because suddenly you become the care recipient. Everybody is taking care of you. It's coming from love. I want a glass of water. No, I'll get it for you. I'll get it for you. We make patients even bigger patients because we love them. We don't want them to do anything for themselves. What we are really doing is taking away their personhood. And unfortunately, sometimes we do this because of just too much love. So one of the aspects of palliative care, and it comes in the social domain, but I also deeply believe that it comes in the spiritual domain, is my ability to contribute to society no matter what my health condition is. whether in the form of helping other people or telling my story or, maybe sharing my learnings, whatever it is. And we want to give that back to people, even though they're seriously sick. To a lot of people, it's about contributing financially to their homes, to their families, and not being a burden, but continuing to be someone of value. So very often our work also means sitting with these people and asking them, what would you like to do? And so here is somebody who, these are just two small examples. Here is someone who had a child with a congenital anomaly, and family abandoned her because, sometimes superstition will say it's the woman's fault. And but she's left at home completely with a child with extremely high dependence needs, cannot leave the house, no source of income. She knew how to sew, so we sponsored like a sewing machine and stuff just to get her started, and then connected her to some other women's groups and so on and so forth. So at least she had that ability to care for herself and her son financially. This is a man who met with an accident and lost the use of his lower limbs. He was an auto rickshaw driver, and so he could no longer do that. So what he chose to do is to make umbrellas while staying at home. And to empower people to continue to contribute to their family's income, etc., is very much a part of dignity. It's very much a part of spiritual purpose, meaning, connection and hope that I am still here and I am still of value. Children are a really important part of our care, and I'll be doing a session separately with you about children in palliative care settings. But one of the hardest hit is the education of children. And there are families who are so impoverished by the disease that they have no choice but for their child to drop out of school, for that education money to be reallocated towards treatment. So what we're really seeing is the disease of one person in one generation having a multi-generational impact on the future of the family, opportunities, and education being taken away. So this is actually a cause of big concern for a lot of families, big concern. And it actually has an impact on how they experience their pain. So I've shared the story elsewhere as well, but when I first joined Palliative India, I knew total pain. Okay, I got it. It's an easy concept to understand. And I accompanied Dr. Rajgopal and some of the home care teams into one of the villages. And it was one of those link center referrals where we were told that there's this man who's in excruciating pain, so we needed to go across. And we couldn't obviously drive right up to his house. We had to walk about, I would say, a little more than, a little under half a kilometer. And this man was screaming so loudly that we could hear him at least 300-400 meters out. And I remember, this absolute assault on my senses when we walked into the house, and it was stinking. It was in such a bad shape. And finally, his wife came forward, and she was so desperate for help. What had happened is he had been discharged from hospital with a feeding tube, with a peg tube. And they said, just take him home, take care of him at home. Now, for us, taking care involves feeding. Food is a big part of how we nurture people. So she was trying to feed him. And what had actually happened was that in the course of all of this, he had developed a bowel obstruction, which basically meant that after a while, he couldn't pass his waste out, and it was actually coming back out the other way. And his pain was 9 on 10, 10 on 10. So cleaned him up, gave him all the medication he needed, etc. And then we asked him, what is his pain scale? And he said 6. Worked with him a little bit more. Not coming below 6, not coming below 6. So finally, Dr. Raj sat down with him and held his hand, and he said, what is bothering you? And as a new entrant into palliative care, I thought it's kind of obvious what is bothering him, right? Like, he's in pain, he's regurgitating waste, whatever. And actually, he didn't answer for a fairly long time, and I'm estimating it to be at about 6 minutes. But have you tried being quiet for 6 minutes? It's a very long time. If we had to just be quiet now for 1 minute, some of us are going to start feeling a bit awkward about it, right? So about 6 minutes go by. And finally, I'm thinking, oh, he's not going to say anything. But he very quietly says to Dr. Rajgopal, all I wanted was for my children not to be fishermen. So he himself was a fisherman. And he said, all I wanted was for my children not to be fishermen. And I thought, what is this answer? So basically, what he was trying to tell us is he knew he was dying. His wife was uneducated. They had used up all their money. They were deep in debt. And the children had dropped out of school and they were going to become fishermen now. And that was his biggest worry and anxiety. So we went back and we run a children's program, education support program. So exactly for families like these. So I think we've supported about 200 plus children in their education. Some of them, I'm very happy to tell you, have chosen to become doctors and nurses. But it usually takes about a week for us to get everything ready. But in this case, we got in touch with a few people and immediately people came forward and said, no, we're going to pledge funds for this family. And they had actually signed on documents and stuff. So we went back the following day and we went back to this fisherman and we asked him, what is your pain? He said 6. Then we showed him all the documents. We said, children's education is seen through till college. And we let him look at the papers and all of that. And then we asked him, so what's your pain now? And he said 1. His pain literally dropped to 1 once he was convinced that this had happened. That is total pain. Had we not asked him that question, had Dr. Raj not sat with him for those 6 minutes, we would never have known what is actually causing this man's pain. So while, there might be people who think, this is like this whole psychosomatic connection and stuff may be a load of nonsense to a lot of people, but we have seen over and over and over again how sitting with the person and understanding their story will actually help us become better clinicians, because it's not always about the physical pain. So this is where also taking over a child's educational needs becomes palliative care. And again, not something that you will see. It's very hard to convince people in the West that this is part of what we do, but it works. And of course, special attention to the elderly, and especially elderly people living alone, because loneliness is an epidemic now, and we need to pay attention to that. I'm going to switch gears now very quickly because I just want to keep some time towards the end as well. Here's something that I want to draw your attention to, and that is we all today, now the fact that you're in this class with me, you are now palliative care advocates, whether you like it or not. So what are we talking about? Why is palliative care still so heavily inaccessible in countries like India and other low income countries? There's a saying that says, if you're not at the table, you're probably on the menu. If you don't have a seat at the table, you are probably on the menu. And this is true because historically, low-income countries have not been at the table. There are 68 million people who are suffering, who have serious health-related suffering around the world. This is the estimate, of which 51 million are in low and middle-income countries like India. 7 to 10 million are in India. This is the estimated number of people who are suffering right now as we speak. And in 80% of the world, there is no access to pain relief or palliative care. Okay, and this is there's a Lancet Commission report of 2017, which is a very, very extensive report. I'll share that with you as part of your learning material as well. And but why is it? Now, I'm just going to very quickly go into a little bit of history. Some of you are aware of the East India Company, how they traded in opium. And that's how actually they built the East India Company and how the British actually managed to build empire around the world. And opium was grown and taken from India. It was sold in China, and then that trade became the basis of their economy in that sense. And and so in a way, the East India Company was the world's first and biggest drug cartel. They knew what they were doing was harming people, but they continued to do it anyway, and they made a hell of a lot of money in the process. When they left after the wars, after World War II, when they left and India became independent, that's then followed the drug control treaties. And this was actually led by missionaries and reformists and stuff who said, no, we want to get rid of drugs. And they started this whole thing on the war on drugs. But also that was helped along by American history, where the civil rights movement was emerging. People were against the government because of the war in Vietnam, etc. And one of the ways in which they could, work against the opposition was to actually associate certain groups with certain drugs and then ban drugs. And that's the way they went after people, to disband them. And the drug control treaties at the UN basically put a lot of restrictive regulations on growing, manufacturing, exporting various commodities, which are now trade commodities. And ironically, a lot of the stuff that colonizers made money on, today they were told that no, countries that are growing them cannot make money off the same thing. And this was all over the 18th, 19th, and 20th century. And it's only in the 21st century that palliative medicine came in, and we said, no, the same medications, narcotic and psychotropic drugs, also have pain relief aspects, and we need to get access to those. So it's just about a few years of advocacy versus 1.5 centuries of regulation and restriction based on some colonial history. And as a result of that, what has happened is this cartography of pain, this map of pain, where today, because of the international drug control treaties, you must be thinking, what is this map? This map is a signature of the Lancet Commission report. What it's really showing you is access to opioids for pain relief and the needs met. So North America is engorged, as is Australia, and so basically they're using more than they need. Western Europe is probably the only one striking some sort of balance, but they also have in excess. Every other country here does not have pain relief. And if you look at all of these countries, they're all erstwhile colonies. Most of them are, at least. And this is what the historical impact has been. And typically, as per the United Nations, when it comes to drugs and medicines, we have to prevent diversion for illicit use, but we also have to make available for medical and scientific purpose. And that's how we strike public health balance. But around the world, the laws and the regulations are more towards control and regulation and not towards access. And all our laws, I'm sure you've heard of the NDPS Act. It was made, I think, infamous also by Shah Rukh Khan's son a couple of years ago. And the NDPS basically looks into these matters, but it is heavily skewed towards regulation and punishment and not towards access to medicines. And as a result of this war on drugs rhetoric, the NDPS, which came into effect in 1985, we saw a 97% drop in pain relief access in India from 1985 to 1997, which basically means the pain burden in the country went up that much. So from 716 kilograms of morphine equivalent being used in the country in 1985, only 18 kgs was used in 1997. I don't know if all of you have read the report that came out a couple of days ago. India is now the leader in cancer in the world. Can you imagine the accompanying pain that we're going to have to face? And our law was so prohibitive. It took 19 years of advocacy by us to have the NDPS amended. And 10 years later, 2014, it was amended. But in 2024, most of the states in India have not yet implemented the new amendments. And we're still fighting for that. So we have a dual responsibility. And we talking about statistics, talking about legislation, etc. What does it mean? What does it come down to? It comes down to individuals like this. We found this man who was bent over in this position for 3 weeks. 3 weeks, he didn't move from here because he was in so much agony. One immediate release oral morphine tablet costing 3 rupees. And he was able to sit up for the first time in 3 weeks and have a cup of tea. That is why we're advocating for the use of affordable opioids. It is not addictive if it is given properly. And yet, less than 4% of India has access to it, which is why we need more of you to start talking about this. And this is just a repetition of that. Now, the principle of balance is when we have to balance out control and access, right? Now, everybody hears about the opioid crisis in America. People are dying because of the opioid crisis, and they somehow conflate it with the access issue. But the truth is that the problem in America is an entirely different one. It came from a pharmaceutical company pushing a particular medicine. It flooded the market. It coerced doctors into overprescription, and that's why you have the opioid crisis there today. We have a bigger crisis in the rest of the world, which is we don't have access to pain relief. And typically, these two groups have been on opposite sides of the debate. There are people who say, no, 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 you have to have restrictive rules because we don't want another opioid crisis. And there are people like us who say, no, we have to have access. But maybe there's a way to bring this both together, and that way is to focus on the patient. Who is the patient? Who needs it? Whether it's a substance use person with substance use disorder or a person with excruciating pain, we have to do what is best for the patient and not, just have these very ideologically, all these conversations in ivory towers. And the way to do this is to focus on the suffering of the individual and the families. We have to focus on safe access. For that, we have to generate evidence that we can use it. And there's a beautiful study that came out of Kerala where in all these years, there's never been a single case of misuse and diversion of morphine in Kerala state. So we have evidence that we can do it, and we have the systems for it. And we have to partner between the government, professionals, and civil society. None of us can do this alone. The government cannot do it alone. Medical professionals cannot do it alone, and NGOs cannot do it alone. And wherever we have seen the model working, like in Kerala, like in Telangana, it has worked only because all three have come together. We use the mighty infrastructure of the government, we use the training and the expertise of the professionals, and the advocacy and the passion of civil society actors. Now, I'm just going to show you a quick video before I close up for the day. And this video Okay, so there are many other videos online about palliative care, and I find that a lot of them are very, West focused. But I thought that this was something that really applies to all of us. And really what we've been talking about for the last hour and a half is this, that palliative care is a social intervention. It's not just a medical one. So anyone can be a part of the movement. We have some time left. So if anyone has any thoughts, questions, reflections, expectations, please go ahead. Yes, Aparna.
Smriti, thanks so much for this session. It's been an eye-opener, and it's actually set me thinking to go far deeper than what's on the surface and to start becoming more aware and, like you said, have your eyes and ears open. And having said that, you mentioned that there is a very robust system in Kerala where there are these volunteers and social workers reaching out into villages. And you showed us one of the cases where the child was very ill and they've requested the euthanasia of the child, which is still not legal in India. There is a similar case which was reported as recent as January of this year, end of January, in Kerala, in Kottayam district. And both the husband and wife are nurses. And they have 3 children. Out of the 3 children, 2 have congenital diseases. And exactly what you mentioned as part of the presentation, there's been a severe financial drain. The family is not even able to provide for food or education anymore. They've run out of all resources. And I was surprised that they're nurses and there was no awareness of palliative care option. So is that still a reality in Kerala where a lot of people still don't have access to palliative care or even the awareness?
100%. And the coverage is not total, Aparna. I mean, thank you for what you shared. In fact, this case has been heavily discussed amongst our circles, not just in Kerala, but we have a national level group that, and of course, the fact that this happened in Kerala came as a tremendous shock to everybody. But we also have to be aware that it was only in 2021 that palliative care became part of the nurses' curriculum. So 2019 is when it became a part of the doctor's curriculum. 2021 is when it became part of the nurses' curriculum. Our big problem today is it's wonderful all the government colleges have incorporated it. Who is going to teach it? because previous generations have not been taught it. So we're actually working with the government now to develop modules and do a training of trainers so that this kind of learning can actually trickle down to it's great that it's on paper. So to answer your question, yes, there are vast numbers of people, even in Kerala, who don't know about palliative care. And it's it's still an uphill battle to try and integrate it to private healthcare hospitals. Majority of the palliative care that you're seeing in Kerala is coming from the non-government sector. I mean, of course, the government of Kerala has been extremely facilitatory in that sense. So Kerala state has the first state policy in the country, possibly in Southeast Asia. We are the only ones who revised our policy in 2019, and barely any other state. I mean, now Orissa has one, and Maharashtra has one on paper. Karnataka has one. That's it. There are no other policies in the country. So we have a very, very long way to go. So coverage in Kerala is not 100%. And this it was appalling, because also part of the reason was that because they had 3 children and they were both nurses, they also had to leave their jobs to stay home and take care of the kids, right? So just because they were nurses didn't mean they had access to healthcare also. Yeah. So thank you for highlighting that case. In fact, I think I should probably bring it into our sessions. And yeah. Shalaka, your question, what has Kerala done differently to have a strong palliative care movement? So if you go into the history of it, it started with volunteers. What has been the strength, I think, in Kerala has been a very, very strong spirit of volunteerism, and this sort of enthusiasm to participate. So the whole history of palliative care in Kerala traces back to that. Like Dr. Raj and Dr. Raj started it in Calicut with a colleague. And it was only when one of their friends came and said, hey, I can help my printing press can help print flyers for you guys. That's how they tapped into the social capital. So they, even today in his book, he attributes the entire success of the palliative care model in Kerala to that volunteer who said, hey, let me participate in this. So it's that has been the primary reason for the Kerala model success. Very difficult to do it in a state like Maharashtra or UP or one of the bigger states. And, it's the indices are very different in those states. So also because Kerala ranks differently in healthcare and education, etc. Those might also play a very significant role. Having said that, I want to tell you about Mizoram, where it has such a strong Christian community. And one of the successes there was that one evening, the Presbyterian Church, the main Presbyterian Church there, they talked about palliative care one evening. And it just trickled down the grapevine. And what do you know? By the next year, all the churches had taken up palliative care as a cause. So there are different channels to make this run. We just have to figure out what it is. In some places, it could be the youth. It could be the young people. During COVID, we had put out a call during the lockdown for young people between the ages of 20 and 40 with 2-wheelers to come for volunteer training with us. And we got permission from the local law enforcement and stuff. The idea was to reach out to elderly people, especially, or sick people living alone, who needed their blood drawn, who had medicines to be delivered or groceries to be delivered. And in 24 hours, we had 97 respondents. And we actually had to cut away a few and say, and it's not that, oh, it's lockdown, said they wanted to loaf. They were genuinely interested in actually being of use. So we just have to figure out who it is in our societies and in our community. Sharla, you have a question?
I don't actually have a question. It's just something that I wanted to share. So where I'm from in Trinidad, what our cause we are championing it is really just about education, because oftentimes in my country, what we're seeing is that palliative care is only introduced when oncologist decides there's no more chemo we can do. So we are really championing that cause to let them know, hey, on diagnosis, let the palliative team come in so you can know about the resources that we have. And just as you mentioned with the total pain, we have seen cases where, you know, they don't just need the pain medication. Their relatives are experiencing extreme caregiver burnout, so they may need a caregiver. So it's so much more that really encompasses palliative care. And I really believe that education, a lot of people do not know about the resources that are there for them. And also, even looking at that mental health aspect, I feel that, you know, we are sitting here and we know about, you know, the challenges of life and how many of our own personal families and friends have been affected by chronic illnesses. And we would have gone through that process really trying to, you know, finding things to make it work, looking for medical interventions. So I really believe that education is really important, always just sharing and letting people know, hey, you know, this is palliative care. It's not only for when you're dying. You could have it on diagnosis. Let's come in, so, and even though if you decide to go chemo, radiation route, or whatever it is, or surgery, we would always be aware and abreast of your case, so that in the event that you need our team to come in, we are aware, so we can all work together in tandem to ensure that the patient has the best quality of life possible.
Thank you. No, that's absolutely vital. And education, and education goes every way. It goes towards the public, it goes towards professionals, and it goes towards decision makers and health ministries. So that kind of education, without a doubt, is one of the pillars of palliative care. We can't move forward if we don't have that education. And education without facilitatory policies and laws will not work. I can have the education to prescribe and give morphine, but if the law of the land does not allow me to do it, then that education is nullified. I might have the medicine, but if I don't have community uptake, my patient doesn't want it, it's nullified. So all of these have to go in lockstep. And thank you very much. That's a very, very important point you raise. Narmada, you have your hand up.
Yeah, so you've been touching on legal aspects of, or rather the obstacles that you face with palliative care. I recently heard, I didn't have the words for it earlier, and in the last 3 to 6 months, I've noticed that we have the concept of a living will here in India. You can write one out. But none of my family members had any idea about it. And I asked some of the older family members that I have to write one out, and someone laid out an instance where they had a living will, they'd given it to, you know, the younger members in their family to execute, in case, you know, they went into critical care or ICU. And the private hospital that they were in just said, no, I'm sorry, we will have liability, so we're not sure about the validity of this. We're not, like, we need to verify it, and therefore we will do interventions first. And that feels extremely wrong. So my question is about the awareness about the legal aspects of palliative care, and also how much the system overrides it.
So we have 3 minutes to answer this. So you are going, sorry? No. So you are going to have you are going to have, we're going to have a session with Roop Gursahani on advanced care planning, end of life care, where he will in detail go into the whole aspects of the living will, etc. So I'm going to, sorry, there's a little bit of disturbance. I'm going to actually let him do that. The prohibitive aspects of the living will have been to a large extent rectified as of last year. Okay, so there is a group called the End of Life Care in India Task Force. Roop is part of it, and they have worked heavily to get this changed. Because earlier, what happened is that because of the Aruna Shanbag case, this is how the end of the living will issue even came up. And India is the only country where we have, in my opinion, quite idiotically gone and called it passive euthanasia, to take somebody off futile life support, to withdraw or withhold futile, I'm talking about futile life support, ventilators, ECMO, all that. When a person is already like say fourth stage, fourth grade, advanced cancer, whatever, we are the only people who've called it passive euthanasia. Now that the word euthanasia itself says, oh, it's a deterrent. Now, with the living will, what we're really doing is enlivening this agency I have to say, I don't want it. I don't want ventilator. I don't want extraordinary measures. And you can actually list it out. Unfortunately, because of the mindset, we're not just changing the policies, Narmada, we're changing a whole generation's mindset towards this, right? And there are people who today, I mean, they are the other way. I want to have the right to euthanasia if I want to, if I feel like life is not worth not living anymore. But it's such a nuanced topic. We have not, in my opinion, again, it's my personal opinion, we have not earned the right to talk about euthanasia if we have not figured out how to mitigate the pain and suffering of our people. Why do people want to be euthanized? To a large part, it's because they're suffering. And we can't skip 10 steps towards euthanasia when we haven't addressed why they're suffering. We have the pain medication, we have everything, let's work on this, So it's a volatile topic, but the system overrides it. You're right in many ways. There's a lot of unlearning that needs to take place. There are lots of doctors who are not aware that ICMR has actually released guidelines on end-of-life care in hospitals. So oftentimes, like Sharla was saying, our job is to educate the medical professionals to say, these are the guidelines. There is a position paper taken by the Indian Association of Palliative Care and the Indian Society for Critical Care Medicine about palliative care in ICUs. A lot of doctors don't know about that. So the education is, it's so necessary. And I'm hoping that in my lifetime, it's done. That's me being optimistic. And hopefully there'll come a day where I'm out of a job. But we have a long way to go. But these questions are so important, and thank you for asking them. And what I will do is I'll work with Ashley to send you all of these different papers that I've talked about, the position paper, we have a living will document on our website that was designed by a bunch of us. There is a guideline book along with that. I'll send you the latest articles about the changes in the living will. And of course, you will have a chance to speak with Roop Gursahani about it as well. So I hope I've sort of addressed it. And sorry, I know Anita's had her hand up for a long time. So this last point, we'll just take that from you, Anita, and wind up. You're muted, sorry.
Sorry. I was just thinking that I'd mentioned in my earlier, when I was talking to you about awareness, would it be possible to put it in the curriculum for any college to put a wee bit on teaching them on palliative care?
I would love for you to take the lead on that project.
Oh my.
I'll support you on it. Do you mean
volunteers? We normally look at college students. We do training for volunteers in our institution here in Cochin. So I was thinking the more volunteers we get it only from college students. They would have some awareness regarding it. So I would think that would be an apt choice of, because when you talk about community, everybody should be involved in it. I would say at last, palliative care at your doorstep.
I'd love that. So Anita, just to give you a sense of this, and we're happy to share information. We have actually worked with the Kerala University, and there is something called the SANS. There's something called the SANS Pain. It's called the Students Against Needless Suffering Group, and over Students Against Needless Suffering. It's called SANS Pain, and I don't know, I'll have to check the numbers, but over 3,000 students in India, in Kerala, have been sensitized to palliative care through this program. And so I'm happy to plug the program. And in fact, it's really heartening to see that on their own, the initiatives that they take, they really come out in full for palliative care. Yeah, so I'll send you some information about that. And if there's any other,
please.
Yeah. Okay. Great. I see there are some.
Okay. Thanks a lot. Thank you.
All right. So we're 3 minutes over time. I will get scolded by Ashley and the technical team if I don't wind up right now. I will share my email address in the chat box. And if you have any other questions, I'll be happy to take them. My turnaround time may not be very quick, but I will try and answer everybody's questions. And Ashley, you and I will work together to just put together all those learning materials that we'd like to send everybody, just in terms of reading up and putting things into context. You'll be seeing a lot of me, unfortunately, over the next 15 sessions. So I'll save some of my other stories for later. But I'm really excited that all of you are here, that you're so engaged. I'm grateful that this group is, taking this course. So hopefully by the end of our sessions, we'll we come together and do something together. So thank you again very much for your time. And welcome to Pallium India for those of you who are interacting with us for the first time, and see you next session. Thank you. Bye-bye.
Thank you, ma'am. Thank you so much.